Okay, welcome to Obesity Canada's community. This is the Hope Series. This Hope Series was created to offer knowledge, to support one another, and of course, to offer hope during this time of COVID-19. I want to let you know that we have people here from all over the world, from Denmark, Iran, Philippines, all across Canada, US, and other countries. This audience is made up of physicians, dietitians, bariatric educators, industry, returning members. We have people who have been with us from the beginning of the series, showing up week after week, and it's been a delight and joy for us to put this on. I'm going to tell you who I am. My name is Sandra Leah, and I am the Vice Chair for Obesity Canada, GTA. I'm also a food addiction counselor here in Toronto, and I'm a patient advocate. I have my own history of living with obesity and overcoming that. So I'm going to take this time to introduce the topic now. Today's topic: the intersection of COVID-19, obesity, diabetes, hypertension. What does the future hold? And so as we begin to now feel that the restrictions are being eased up, and we're coming to terms with the fact that people who are living with chronic diseases like obesity, diabetes, hypertension, how were they managing during this time? And what is the way forward in managing these diseases? So I'm going to turn it over to Dr. Arya Sharma. He is the Professor of Medicine at the University of Alberta and the Scientific Director of Obesity Canada.
Yeah, thanks, Sandra, and welcome everybody to our, I believe it's the 6th event here in the Hope Series. So just to remind everybody, Obesity Canada is Canada's national registered charity, which is entirely dedicated to improving the lives of Canadians through obesity research, through education, and through advocacy. Through its work, Obesity Canada educates health professionals, supports researchers, mentors, trainees, and students, and works with policymakers right across the country to ensure that all Canadians living with obesity receive the same level of prevention and care as Canadians living with any other chronic disease like diabetes or hypertension. Which brings me to today's topic, and that is chronic disease, and how are we doing with chronic disease in these times of COVID. I recently saw someone talk about this, and he was really talking about the waves. So we've had the first wave, which was the first rise in infections that we've all experienced. Now we're talking about the second wave, and then there might be a third wave, and the third wave is something that is perhaps different. And the third wave is really getting back to dealing with all the health problems that have been postponed. So all the elective surgery that didn't get done, all the elective stuff that needed to be done that people have been waiting for that wasn't done. Well, that's now going to be the third wave. And then unfortunately, there might be a fourth wave, and that fourth wave is going to be the consequences of chronic disease that was poorly managed or not managed or uncontrolled during these times of COVID. And because a lot of people have not seen their doctors in the last 2 or 3 or 4 months and might not be able to see someone. And we know that for a lot of chronic diseases, there have been issues. So that's going to be the topic today. We will have a brief discussion with our experts, and then we'll open the floor to any questions that you might have. So our first expert on the line I'd like to introduce is Jonathan Gabor from Winnipeg. And Jonathan, over to you. Perhaps you just want to introduce yourself quickly, tell us about yourself, your interest in obesity, maybe your practice, and your relationship to Obesity Canada.
Perfect. Thank you so much, Arya. So I'm a relatively newcomer to Obesity Canada. I'm a relatively new board-certified physician in obesity medicine. My day-to-day practice is what we call in the business cardiometabolic disease. So hypertension, diabetes, dyslipidemia, managing cardiovascular disease, other types of vascular disease. My foray into obesity has come basically out of my interest in those particular conditions and how obesity impacts those. I'm also the chair of the Winnipeg chapter of Obesity Canada. So we're a small group, but we're a happy and motivated group, and we're just happy to get off the ground.
Well, thanks, Jonathan. Great to have you. And Shawn, you want to tell us a little bit about yourself? You've been involved with Obesity Canada, I believe, from day one almost. You're a former boot camper. You might want to talk about that too. So tell us about your story.
Thanks a lot, Arya. That's great. Thanks, everyone. So I'm an internal medicine physician. I work in Toronto. So and how I came to obesity, really, I was working as a resident within the hospital system, and looking at at high blood pressure, cardiovascular disease, and diabetes, specifically in the Black population was what I was looking at. I was interested in that. And then I saw Dr. Arya Sharma do a talk on obesity management. And in my group of people live, Black patients in America suffer with obesity all the time. And that leads to hypertension, that leads to diabetes. So we're always trying to manage these conditions with medications, just throwing them on top of the problem. And the problem frequently was the patient's elevated weight within the room, but nobody wanted to actually talk about it. It was as much of a castaway issue as some of the racial problems that we face on a regular basis. So it felt really connected for me to work in the obesity field because it has as many biases, challenges, and stigmas that I faced throughout a lot of my life and a lot of my people face. So it made sense to me to work in a field that needed to get better, needed to be better, needed to be recognized. The people needed to be recognized and understood. So that's where I came from in this field, and I've been working in it since, and it's been nothing but a great field to work in because there's so much to actually do.
All right, so Shawn, let's dive right into this. We've talked about hypertension, we've talked about diabetes. These are all chronic diseases. What do you think is the biggest challenge for you and for your patients? Ever since this whole COVID thing has started, what has really been the impact on this on some of those issues?
Yeah, it's interesting because as much as we think that COVID really caused a big challenge, I don't really feel that it did. The bigger challenges in the obesity field is the lack of understanding of what obesity actually is and some of the biases that we attribute towards what weight management is, some of the lies, some of the myths that if we just get a better diet, everything is going to go well. I think it's really put a highlight on the fact that there's a lot of emotional stress, there's a lot of brain pathophysiology that's connected to this. And if we can get our brain a little bit better, if we can have attention to ourselves, love ourselves a little bit more, recognize that we're important people. And if you're important, then you're important enough to get care and to get treatment and to understand what the medical problem is. So I think that's really shone a light on that this is not just a simplistic condition, but it's wrapped up in a lot of psychology, a lot of emotion, a lot of social challenges. And I think that we're here to try and address that.
So Jonathan, let me ask you now. Now we've learned that COVID does not affect everybody equally, and very early on in the epidemic, we saw that people who have other chronic diseases like hypertension, like diabetes, like obesity, are at a much higher risk of getting complications. So if you focus on hypertension as a risk factor for more severe complications, why do you think that is? What do we understand about the link between hypertension and COVID?
Yeah, so it's true. So, as they started analyzing the data, they saw that people who had severe COVID, and one can define severe COVID in different ways, but generally accepted severe COVID is COVID bad enough to either get you into an ICU, get you on a ventilator, or unfortunately kill you. So people who had severe COVID, among those people, the incidence of several conditions such as hypertension was higher, right? Now, of course, there was also an association with age, right? And then the question became, well, were those other factors simply something that happened to correlate and move along with age, right? If you're older, you are maybe more likely to have hypertension or diabetes or obesity. But as they started to tease it out, they still found, particularly in the case of hypertension, they still found that this was one of the most, if not most common risk factor, cardiovascular risk factor that was represented in the population, the subset of patients with severe COVID. Right? And then, of course, the question became, as I said, why, right? Is there something about hypertension, or more specifically, and this is where the controversy with the medications came in, is there something about one or more of the medications that people take that might have predisposed them to severe COVID, right? And that's where the controversy got generated, right? In the end, and of course I'm happy to expand on that, but in the end, of course, that turned out not to be the case, right? It was more of a theoretical concern. But in general, folks who were on any medication certainly did not have an increased risk of bad outcome from COVID. And in fact, when they dug down a bit more and even pooled data from study A and study B and C and D, they actually found that perhaps there was a trend towards actually slightly less mortality, right? In folks who, definitely in folks who are on any antihypertensive medication who had their hypertension controlled, and even in the medications that had initially been suspected or accused of perhaps increasing risk.
So Shawn, let me ask you, I mean, we've known this, that there's been this link between obesity and hypertension for a long time. And in fact, I think it's fair to say that obesity is probably the biggest risk factor for developing hypertension in the first place. Although a lot of skinny people have hypertension, but the vast majority of people who have high blood pressure, you find the blood pressure goes down when they lose weight and goes up when they gain weight. So can you explain from what you know about the link between obesity and hypertension, what that relationship might be, and why controlling obesity is such an important part of trying to get better management for hypertension?
Yeah, so I think that's an important thing. And what we really see is that the risk of anything coming from obesity comes from the central adiposity. So when your belly is big and your legs are thin, that's when there's more of a problem. So what we know is that when you take in energy, you can put that energy into one of two spots. And when it comes to fat, if you're an African American woman, you make better fat cells than a white male does. A white 50-year-old male doesn't make fat cells well. An African American woman does. And what they do is they take that energy and through our system, they dump it into the peripheral fat cells. So that means the thighs and the breast area. There's no disease there. When you can't make new fat cells, you take the energy and dump it in the fat cells that you already have, which are the closest ones in the central area in the belly. And then that fat cell gets bigger and bigger and gets toxic and starts sending off these toxic adipokines, we call them. TNF-alpha, IL-6, these are inflammatory markers. They go everywhere. They go to the brain, they go to the vessels, the vessel walls. They make the vessel walls harder. As the vessel walls get harder, hypertension happens. They go to the lungs, they cause damage within the lungs. So if you have central adiposity, and the people who are at risk are white males, South Asians in general, and also the First Nations people. So as opposed to African American women or white women have a greater ability to put energy into peripheral cells. They may have mechanical, like osteoarthritis or urinary incontinence, but not the high blood pressure and the heart disease that we see with that central hard belly. So that's the connection, the inflammatory connection.
So let's talk about chronic disease management in general. And when you come back to the definition of chronic disease basically is a disease for which we don't have a cure, which means once you get it, you pretty much have it for the rest of your life. Which doesn't mean things are hopeless, because for many chronic diseases, we do have good tools that allow us to manage chronic diseases. And we have programs that help you manage chronic disease, and there's lots of chronic diseases out there. So, can you maybe, Shawn, take us through what are the key principles of chronic disease management that apply to any chronic disease?
Right. Yeah, and I think that the important part is the hope part, which is why I like the fact that this is called the Hope Series. So we know that even if you have a chronic disease, it can be controlled. But when you let your foot off of the gas, if you're controlling it, let your foot off the gas, it is coming back. That's the important thing. It's coming back. So how can we keep our foot on the gas of the treatment that we are looking for? The use of medications definitely helps, and the use of getting healthier behaviors. And healthier behaviors is way more challenging than starting a medication. And we have Sandra Lee and Rachel here, Atkins, who really understand the idea of how we can make behaviors better, how you can integrate it into your life on an ongoing basis. We know that the diet, eating better with a behavior that you can do on a regular basis, drops your blood pressure more than a single medication does. But most people can't do diet over the long term. So that's why doing good behavioral modification and sticking to it with the tools that we have is very hopeful, and we can actually do it.
So Jonathan, let's talk about behaviors for a second, because behaviors are important, but also taking a medication is a behavior, and going to see your doctor is a behavior. and following the instructions, even just taking that prescription that your doctor gave you to the pharmacy and getting it filled is a behavior. So those are all behaviors that we know, sometimes are not followed as closely as they should be. And this goes for all chronic diseases. So Jonathan, what's your thought on that, and what is it that you can do, as a clinician, but what is it that you think your patients could do to really, stick with those behaviors? Because, there's a big difference between starting something and doing it for a while and then continuing to do that for forever.
No, that's a very good point. And further to one of Shawns' earlier comments, I haven't shut down my practice at all. In fact, my practice is still motoring, and I'm doing, patients are starting to come back to the clinic, but for a long time during the thick of it in COVID, I was doing phone visits, what we call phone visits, but basically phone calls, right? Calling a patient and checking in. And again, further to Shawns' point, the first words out of my mouth when I'd call these patients would, "Hi, it's Dr. Gabor. How have you been coping during these pandemic times?" Right? Because that gives me a sense of where they're at, stress, anxiety, and the relationship of that, of course, to a deterioration, shall we say, in health behavior patterns, right? So I got to take them at their word. If they tell me they're doing fine and the conversation proceeds well, then great, right? But of course, at other times, they're not doing fine, right? And I'm not a pessimistic man by nature. Most of the time, I've had good success with the patients, and they've been keeping steady during COVID. But there's a reasonable minority that unfortunately haven't, and something has slid down. Is it, what we say in the business, is it adherence to a medication regimen, especially if they're on multiple meds, right? Some of them are more expensive than others, and some people have lost their jobs, right? Is it, again, a behavioral, yes, taking a med is a behavior, but again, is it something along the diet and lifestyle route, right? Some folks, I service a large rural population as well. So some folks say, hey, COVID's not affecting me at all. I still go for walks, I still go for bike rides, and hey, that's amazing, right? Other people not, right? Other people tell me they've gained weight, right? What we hear in the media, the COVID-15 or the COVID-20, whatever it happens to be. And has that happened to my patients? I'm sure it's happened to Shawns' patients, for sure, right? And there's usually one or more reasons for that. It's not just one thing, but even that disruption in a daily routine that had taken a lot of effort to establish, well, that's bad, right? So most of my visits, again, are checking in, and checking in frequently. Obviously, as doctors, we all follow different patients at different intervals. Some of us follow a certain patient at 1 month, 3 months, 6 months, a year. But I am trying to keep in touch with my patients a bit more frequently, even if it's just a quick 5-minute hello.
Yeah. So let's talk about the quick 5-minute hello and the fact that virtual visits, once we get used to the idea, are actually, in fact, a lot easier than having the patient come to your office. And it's definitely a lot easier for the patient. You don't have to travel, you don't have to, you don't have to park, you don't have to do all those things. And you said, you've got a lot of rural patients who have to travel long distances. So in some ways, what we've learned thanks to COVID, we now know that doing virtual medicine, which we've been talking about for a long time, is actually very much doable. So, what's your quick take on how this might actually help us improve long-term care for chronic disease management in general?
For my rural patients, it's been amazing. It really has, right? Manitoba's a wide and long province. Me being based in Winnipeg, if someone is coming in, driving in 2-3 hours from a rural town, just for me to say, hi, how are you? Let's look at your blood pressure sheets and let me renew your medications. Well, that's not ideal for them, right? That kind of thing can all be done remotely, and I've had good success with that. And the patients have indeed been thankful. That saves them, 4 hours of their day, right? So if it's a patient who is connected, if it's a patient who is able to chart whatever it happens to be, their blood pressure, their blood sugars, if they can chart that at home and review those with me by phone, fantastic, right? Eventually, of course, someone does need an examination depending on their condition, so it's not the answer to everything. But I think you're absolutely right, Arya, and I'm sure Shawn can back me up. Like it's actually been helpful in many more circumstances than it hasn't been.
So, Shawn, what's been your experience? You work, in the GTA, which is for people not from Canada, will know it's a very densely populated area. But the commutes might also be 2 hours because you're stuck in traffic. So what's the story at your end?
This has been terrific for the field of obesity management. COVID is a horrible condition, but what it has done is allowed the people who are trying to work in the virtual space and expand their reach to patients to be just terrific. I have people in Toronto that would not come to my clinic because it was on the east end of the clinic and they live in the west end. Their doctor wouldn't even refer them. They're like, I'm not sending them there. They're not going to go. It's not going to happen. Things are going to go badly. Forget it. Thanks, Sean. I'm not sending them. And so now I can see patients from all over the province. Patients are extremely happy. They are very happy for the phone call. They're very happy for the visit. But typically, if they showed up at my clinic and I had a very difficult patient that I was seeing, a very challenged one who had renal failure and some heart disease, and they're waiting in the waiting room longer because I'm with a sick patient, they're not happy. This doesn't happen anymore because they're at their home and it's much easier to make the actual phone call. So I'm reaching more people. I'm reaching happier patients who are ready to listen and ready to be part of that education process because they're not angry, screaming. And it's just been it's been really an ability to have physicians refer patients to me to be in a better position and be happier about doing it, the patients to be happier. On an overall standpoint, virtual medicine for obesity care is winning, a winning solution, essentially.
So it almost sounds like you don't want to go back to the old days.
I do not want to go back to the old days. And what Jonathan said is for the patients that need an examination specifically, we will look at that and have a space for them to actually come to, so that we can actually see them physically. But in general, this is the new phase. I'm not going back to a dial phone either. There's not a reason to go back to a dial phone, and there's no reason for us to go back to purely seeing a patient within the clinic. We've proven, and we're doing the research on it. We're not just going to leave it to chance. We're actually doing the clinical research at our clinic where we're getting people to sign a consent form so we can publish how well did you do during virtual medicine versus how well you did before virtual medicine. And we'll be publishing that.
Okay, great. So Jonathan, before we open the floor, just a few sentences from you perhaps to the idea of how an organization like Obesity Canada can actually use the momentum and try to improve care, be it in virtual care or care in person for Canadians living with obesity. What do you think, an organization like Obesity Canada can be doing and obviously, is doing? So any comments on that?
Well, again, possibly biased as it is of me to say this, and again, backing up Sean further with the virtual medicine component, something that Sean and I were talking about last night is all the messages that are coming from health authorities and advocacy organizations is to stay in touch with your doctor, right? Re-emphasize that message, right? Our clinics are open, so to speak. They're open. We're available. We're busy, but obviously that doesn't change, and that's never going to change. So, to drive home the message, if you have a chronic condition, if you're being followed by one of your doctors for a chronic condition, please stay in touch with them. So,
and Sean, any comments on what Obesity Canada should be doing, in addition to what it's already doing?
Yeah, well, I think that the advocacy for the billing codes to continue on in this virtual realm, I think that trying to do research and trying to show that virtual care gets to patients who we normally could not get to. The patient that did not want to come out of their house because of stigma, they'd be stigmatized, or they had to actually, they physically couldn't make it all that easily. And we see a lot of those, and they don't come all that often. The ones where making it out in a snowstorm is more challenging because they may slip and fall, and there may be other challenges. I can reach all of those. This should not stop. This has to keep moving forward. Obesity Canada can help us to actually do that by saying that this is important for people living with obesity, and it will help all the other medical conditions if we can treat these patients properly.
Okay. All right. So I'd like to, thank you, first of all, both of you for your comments. And I'd like to turn this back to Sandra so that we can open up the floor for questions, because I can already see in the chat that there's a lot of questions.
Yes.
So Sandra, over to you.
Yes, so the floor is open for your questions, your comments. If you wanted to share a situation that you're trying to work through right now and you have some great minds to tap into, the floor is now open. So you have a couple of options to do that. If you roam your mouse, you'll notice there's a participant button. You can go ahead and hit that. You'll find your name and there's 3 little dots and you can virtually raise your hand. I'll also, if you can't figure that out, I'll be looking for hands raised in the window. When you ask your question, please introduce yourself. Let us know where you're calling from and what your field of expertise is. And you can also put your question in the chat box. So the floor is...
So I'm going to ask the first question. Jonathan, I see you're playing the bass as well. What is your favorite song on the bass? I got one right here too, brother.
Fantastic. Work-life balance, I don't think I've touched it that much. And in fact, I can say in front of a live recorded audience that I haven't touched it that much, but the intention is there, right? The motivation is there.
Right on.
Oh, great. Rachel, is there anything in the chat box? Because I can't, no one seems to have their hand up.
Yeah, no, I'd love to start. I have a couple of questions. So I'm Rachel, and I'm the Director of Strategy with the Toronto chapter of Obesity Canada. So a couple of questions I've seen so far. I'll start with one from Ruth Ann. So Ruth Ann is wondering, is COVID less related to our genetics, or I should say the severity of the impact of COVID? Is it less related to our genetics and more with respect to how we personally take care of ourselves and our personal health situation?
Oh, so we've got the famous, nature versus nurture question here. So Shawn, you might want to take that. How important are genes when it comes to, complications for COVID? But, if you want a bigger picture, how important are genes for chronic disease to start with?
Right. So that is a confusing and complicated question. And thank you for asking it, though. And it's all a big mix. So what I sometimes tell patients is that if you have a bucket, if the condition is your cholesterol level, and you're like, why is my cholesterol high? Is it because of genetics or is it because of what I'm eating and what I'm doing? I'm like, I don't know. But if you think of a bucket, the bucket can be filled with genes and with the nature, what you're doing in terms of your eating. I don't know what that bucket looks like for each person. So frequently what we do is we will implement a behavioral modification, eating better, living better, all of those things. And if your cholesterol gets terrifically better, then your bucket was filled mainly with a lot of nature, a lot of environmental stuff. Did I say backwards? Nature and nurture? I did. Haven't I? So the environmental, your bucket is filled with more of the environmental stuff. It's not filled as much as with the genes. But if it doesn't budge, if you've done everything, you've lost weight, you've changed your diet, and your cholesterol levels are still really high, it's genetics. It's time to start a medication because that's the only thing that will end up bringing it down. It's the same thing with COVID. Both. Mix of both the genetic components and the environmental challenges. And which one is worse for which patient, which time, we don't know. And so that's why you should live as healthy as you possibly can, because if your genes are bad, then it could be a challenge. But live as healthy as you can, because that's the most we can do, because we can't change our genes, but we can change the behaviors that we actually do.
Sandra.
Yes.
Or
yes, I'm
Rachel.
looking, no hands risen. So back to Rachel in the chat box, because I know there's a lot of activity, but please speak up and join the conversation.
Yeah, absolutely. I'm happy to recite the questions, but we'd also love to see some new faces. So the next question is actually from Mike. So his question is, if a person is hypertensive and or diabetic, but his or her hypertension or diabetes is controlled through treatment, are they at the same risks of the COVID, severe impacts of COVID, as someone who maybe is not really controlling their conditions?
That's a great question. So Jonathan, you might want to fill us in on that.
Sure. So what we know, and we in the quotation marks, right, what we know is that while we see an association between having hypertension and greater severity or risk for greater severity of COVID and poor outcome from COVID, the very same analyses and studies show that the people who really do worse are the ones whose hypertension is not managed, or even specifically the ones who aren't on medications, right? And they saw that out of China mostly. that folks with that of the folks who died or who had a more increased likelihood of having a bad outcome, it was the folks who weren't on medications of any kind, right, that were at greater risk. So can I tell you that the risk is exactly the same if you have perfect hypertension, perfectly controlled blood pressure versus maybe just a little bit off? No, but certainly what at least is known thus far, early on, but thus far, is that having control of the condition is beneficial. It does improve your odds.
Okay. All right, let's take another question.
Yes, Ravi. Ravi, can I ask you to unmute yourself and go ahead? I know that Ravi had a question. Oh, hello, there you are.
Yeah, hi, I'm Dr. Ravi Kamapalli. I'm an infectious disease doctor, but also a wound care specialist and a board certified obesity medicine specialist. So, I mean, like for the first question, I just wanted to kind of show if you, I just like to propose this idea. I don't know what Dr. Sharma would say on this. If you're able to see my background here, are you seeing the background wherein you have two triangles?
Yes, sure, go ahead.
And then basically what I say with those two triangles is I'm trying to push the concept of disease triangles. Like when I was taught in medicine in the beginning, we were told, you were born with these genetics, you have environment, your lifestyle, you can't do anything about it. But what I've kind of over time, when I gained my own weight and I had my own high Lp(a) issues, and I understood that I could change my diet, lose weight, and my Lp(a) halved out. So Lp(a) is a cholesterol molecule. And that made me, as an infectious disease doctor, go back and look. And now I understand a little bit better. I don't understand it completely. I'm still confused. After 20 odd years of practicing medicine, is that there's a lot more than what we are told. It is about immunology. It is about lipidology, microbiome, and microbes that interact with the genetic system and epigenetic factors. Yep. And so that is my concept of what I'm trying to push and share my knowledge. And that's why I saw that I've been following Dr. Sharma for some time, and quietly. But I saw the name and I just said, let me pop in today. So
yeah, so Dr. Ravi, thank you so much for those comments. And I think you're absolutely right that sometimes we tend to oversimplify things. But just to some of the points that you mentioned, some people actually do think that, because it's genetic, I can't do anything about it. And that is fundamentally wrong. I mean, for almost all genetic conditions, we know that that lifestyle management, can play a role. Even when you have a high genetic risk. So Jonathan, what would you have to say to a patient who says, this diabetes, it's been running in my family for generations, so I don't really see that there's much I can do about it. How would you respond to a patient who makes that kind of a comment?
Well, I would simply say that politely, of course, that's not the case. I mean, Shawns' point said it best. You live the healthiest life that you can, and with respect to dyslipidemia, I have a line that I say to patients sometimes. I say I know it sounds stereotypical, but I say I have in my practice 65, 70-year-old men with very poor diets and who have obesity their whole lives, and their cholesterols are perfect, and I have 25-year-old vegan marathon running women who have high cholesterol. And again, to back up Shawns' point, that's genetic, right? And how much can you fix when you're already a vegan marathon runner? I don't know, right? So it's obviously it's a patient by patient approach, of course, as it always is. But that encouragement away from the despair and the resignation, basically, that it is to say, oh well, can't fix that. That's our role as healthcare providers to try to alter that thinking.
So Shawn, I have for you the question, because Ravi also mentioned the importance of immunology and inflammation in a lot of these chronic conditions. And we know that certainly for obesity, inflammation or chronic inflammation can play a huge role and may in fact explain why obesity and why obesity is a risk factor for COVID. Any comments on that, on the role of inflammation in obesity?
Yeah, so really when it comes to all diseases, as we learned in internal medicine as a resident through school, inflammation causes all diseases. Osteoarthritis, it causes strokes, it causes Alzheimer's, it causes heart disease, it causes, you name a disease, it's due to inflammation. So if you've got a cell that is causing the inflammation, you're at risk of all of those diseases, from a DVT to a heart attack to everything else. And those inflammatory markers may be going to the lung tissue and causing little nicks and scratches within the actual lung tissue and allowing for virus to come in a little bit more. On top of that, that inflammatory condition may make our innate immune system a little bit dysfunctional. So what we see is that people living with obesity can't build the proper B cells or T cells or antibodies. We keep hearing about the fact that we're going to be testing blood for antibodies to see how well you fought off COVID. Well, people living with obesity don't develop those antibodies all that well. So they may be at more risk for, potentially more risk for getting it, although that is not absolutely true, but definitely at more risk for developing other chronic conditions that put them at risk of getting COVID, and also definitely of making it worse and worse, all due to inflammation, and inflammation is the immune system. So we need to always study it. That's why obesity has become just not a little thing about how much weight do you have. It's about what does it cause with all these conditions, and why, and how can we fix it, and how can we dampen the inflammatory condition. So we may start to use in obesity the MABs, the biologic agents that dampen the immune response and the inflammation to stop the diseases that are caused with somebody who's living with this condition.
Okay, all right, Sandra.
Yeah, we have a few more hands up. So Rosalind, I'm going to ask you to unmute.
Yes, hi.
Hello.
Hi, Sandra.
Hello, good to see you.
I have a question. First of all, I come from a family background. My mom and dad both had diabetes and high blood pressure. I have 4 brothers with diabetes, and 5 of us have high blood pressure. Now, my blood pressure and my diabetes, they're both controlled by diet and exercise, but I've been told that it's recommended that I stay on both medications. And my question is, what is the benefit of me staying on both medications for blood pressure and diabetes if they're controlled?
Yeah, so, that's such an important question. And in fact, in the context of obesity, we hear this question all the time, where people say, you know what, this medication has helped me lose weight, but now that I've lost the weight, do I need to continue taking the medication? In fact, we have to tell patients often that, well, if you discontinue, your weight's going to come back. So maybe to you, Shawn, why is continuing medication or continuing treatment so important in chronic disease? And how would you respond to this question?
Rosalind, that's a terrific question. I absolutely love it. Okay, so we'll attack it in two different ways. If somebody's blood pressure goes from 170 down to 120 on a medication, and even if they've made a lot of changes, that blood pressure medication may be helping the blood pressure to stay down. If they stop it and their blood pressure goes back up, then there's clear evidence that staying on the medication is an actual positive thing. But apart from that, let's say that you're living with high blood pressure, you bring the blood pressure down, but you also change your life, you're eating better, you're moving better, your blood pressure stays relatively good even when you stop the medication. What are you still on it for? The reason why we still recommend it is everybody grows older every single year. As you grow older, there's other chronic conditions, other inflammatory conditions that you end up having. And but more so, we have seen that the use of the medication does more than just bring the blood pressure down or bring the blood sugar down. It actually works in the vessels and makes the vessels healthier. It goes to the heart and makes the heart healthier. How does it do that? We're not exactly sure, but a person with a blood pressure of 120/80 on a medication dies less than a person with 120/80 who's not on a medication. So that's why frequently in the diabetes guidelines, they don't ask you what your cholesterol level is. They say, go on a cholesterol lowering agent. It somehow has an anti-inflammatory condition, makes the vessels nice and smooth, keeps you from having a heart attack, even when you're not talking about lowering the cholesterol levels. So that's why your doctor has told you to stay on those 2 medications.
Okay, back to Sandra.
Yes, Tanya, you can unmute yourself.
Now let's try to keep
everyone.
Hello.
Oh, sorry, go ahead. Go ahead, Dr. Sharma.
No, I was just saying, let's keep the questions short and let's keep the answers short so we can try to get as many in as we possibly can. So go ahead.
Sounds good. Sorry that my video is off. I'm having internet issues, but hello. My name is Tanya Nagpal. I'm from the University of Ottawa. I'm a postdoctoral fellow and also a proud member of the OC SNP group for a number of years. My question is for Dr. Jonathan. You had discussed sort of towards the end about behavior change and adherence to behaviors such as medication adherence and how this situation may have been impacting adherence, like you gave the job loss example. I just was wondering if you could comment on the fact that there's so many intersectionalities that contribute to behavior change and adherence to these recommended behaviors from healthcare providers, including with COVID, that in itself may be increasing stress, or even the fact that the way care was being delivered to these patients who were used to in-person appointments has changed. How do you support those patients and how do you still motivate behavior change, given that there's so many factors that contribute to adherence?
Oh, no, absolutely. It's, I like to think of it almost as a moving target. That the behavior change isn't necessarily, we all want it to be, but it isn't necessarily something that just happens once and stays that way, right? Of course, we know that unfortunately doesn't always happen. So I think the thing that sort of gets me through the day, and I try to, of course, translate that over to the patients, is that it is something that requires, I guess, vigilance is the best word, to know that there's a possibility, and again, not in a negative way, not to be negative, but just to be vigilant, right? That there are numerous things that can affect adherence to any sort of behavioral strategy, right? So what it happens to be for that person and what their vulnerabilities are to a decline in a good behavior. Of course, different for different people, but I guess the short answer would be that if the interaction with the patient is always about maintaining vigilance for what could be a factor that decreases a good adherence, then I guess that's the best one can do.
Okay, great. So Sandra?
Thank you.
I'm going to pass it over to Rachel and see what's going on in the chat box.
Excellent. We've got quite a few questions there. So we have a question from Rebecca. Question is, I saw there is some early new information about vitamin K deficiency and death from COVID-19. Can any of the speakers speak to this information, particularly incidence or prevalence of vitamin K deficiency in persons with obesity, diabetes, and hypertension compared to those without those conditions?
Yeah, so maybe another question for Jonathan. So just explain to us, what is vitamin K? Why do we need vitamin K? What's it important for? And how common is vitamin K deficiency? And then what does this have to do with COVID? And maybe just one sentence. Sorry.
Yeah, okay. Yeah, no worries. So vitamin K is an essential vitamin. It is involved in appropriate clotting of the blood, right? So absolutely essential. It is a fat-soluble vitamin found in fat. So it is, of course, conceivable that extreme restriction of fat would prevent, like fat intake, extreme restriction of fat intake would prevent one from getting sufficient vitamin K. As for its role in COVID, well, I mean, one could say I don't know that it's 100% certain by any means, but we know that one of the bad things that happens in COVID is overabundant, excessive blood clotting at the level of the very small blood vessels, not necessarily the huge ones or aorta or anything, but the small vessels, especially the ones in the lungs, right? Where there's already, as Shawn alluded to on a number of occasions, where there's already a lot of inflammation and bad things happening right at the level of all the molecules. So I mean, one can make a connection in that way, but certainly from the obesity standpoint, again, if someone has still adequate nutrition, they just have to make sure that all vitamins are covered, including the essential ones.
But you would not be recommending that somebody take vitamin K supplements to prevent COVID complications at this point?
Yeah, I can't.
Or for that matter, vitamin D or any vitamin?
Yeah, we can't do that. Yeah.
And that's happened to me.
Okay, we have another question.
Sure. So the next question in the chat box that I saw was from Lori, who is a nurse specialist in sleep medicine. And she's wondering if anyone can comment on how you think sleep generally, sleep disorders, and sleep behaviors play a role in obesity and other comorbidities, and perhaps certainly in the context of the situation that we're in right now.
So Shawn, you want to take that?
Well, it's actually Jonathan's field of practice. So Jonathan,
Okay, well, then John, yeah, you're the sleep guy.
Yeah.
Go ahead.
Yep. Happy to help. So, I'll be positive and then I'll be negative. So on the positive side, I've actually still been able to diagnose sleep apnea even during COVID, and manage sleep apnea even during COVID, all virtually. Okay? So for folks in the audience, so sleep apnea, this condition where people periodically, intermittently stop breathing overnight during sleep. It is tremendously disruptive to the normal, natural, physiologic sleep cycles. People wake up feeling awful. People wake up feeling like they haven't slept well, and that obviously impacts their function throughout the day. Sleep apnea is undoubtedly more common in individuals with obesity, due in large part to the mechanical nature of the fact that the excess body weight is actually in some ways even pressing on the upper chest and the neck where sleep apnea occurs. So again, within COVID times, a lot of the sleep tests that I administer are actually home tests. So maybe somewhat before COVID, people were able to go to a place, pick up a home testing unit, take it home, sleep with it, bring it back. The results were uploaded to a cloud and then delivered to me. And then I would call the patient back and say, well, I think I have an explanation as to why your sleep has been poor. So for managing that, I've been able to try my best to do that virtually, so to speak. Overall, in terms of the effect of COVID on sleep that isn't related to sleep apnea, well, again, it's always the same typical players: disruption to a person's normal routine, normal habits, stress, anxiety, of course. That's an obvious contributor, right? And what if it's a combination of both, right? So someone whose sleep is already poor because of sleep apnea, well, the last thing they need is to shave off an hour or two of sleep time because of all these other things that are going on. So again, starting off positive, going to negative, but unfortunately, yeah, it's an impact. Gotta say.
Okay. All right, I think we have time for one more final question.
One more question.
Sandra? Yep.
Yes. Can I ask Steve to unmute himself? Introduce yourself and ask your question, please.
Yeah. Hello, everyone. I'm Stephen, family doctor with special interest in obesity and lifestyle medicine. So my question is to Shawn. Actually, in diagnosing obesity, we use the EOSS system. So in case a patient with diabetes, so they are obesity class 2 to 3 and staging of 2. If they reduce weight and reversal of diabetes or the diabetes become pre-diabetes, how would we label this type of patient? Because will we say this obesity in remission? Can you comment on that? Thank you.
Right, I love that. Obesity in remission. Maybe we should start using that. But so certainly I think that when we reclassify them, we'll reclassify them as someone who moved from EO stage 3 to someone who moved down to EO stage 2 or 2 on 1. So that's just as good. I mean, maybe be the best marker for them. Your waist circumference got smaller. This is your new life. Your life is better. Your EOS classification is better. So I think that that's positive for you to feed back to the family doctor, to the patient, to the patient's family, and that will help keep them motivated. Because one of the questions on the chat line was, what keeps people motivated? And what keeps people motivated is success. Success in the fact that their life is getting better, that they feel better, that they think people are positively helping them. They feel successful, they feel cared for, they feel loved, they feel that they're moving in the right direction. So you are doing that for them, Stephen, by doing that and telling that they've changed their classification, they're getting better. So that's very positive.
Okay, so thanks, Sean, for those comments. Now, I mean, I've also been looking at the chat box. There's lots and lots and lots of questions that we haven't gotten to, unfortunately, because of just the time issues. But I do hope that we've covered, you know, a range of topics, and this is certainly not the last time that we'll be doing this. So on that note, perhaps I'd like to thank both of you for taking the time out of your busy schedules and being here on this chat. And on behalf of Obesity Canada, I'd like to thank all of you for attending. And I'll give it back to Sandra for some closing words.
Yes, thank you so much. Obesity Canada is a charity, and the way that we do this great work for both educating doctors and patient advocacy is through your donations. So in the chat box, you will find a link so that you can go ahead and donate. You'll also receive a survey to complete. Please let us know how we're doing and topics that you would like to hear in the future. And tune in next week. We'll be back again on Thursday, this time at 11 a.m. Eastern Standard Time. And Dr. Arya Sharma will be hosting, and we will be talking to Dr. Ali Zedner on coping with self-isolation during COVID-19. So just in closing, we hope that you've really enjoyed this series so far. And if you wish to be a part of it, we are offering sponsoring opportunities at various levels. This series started over 6 weeks ago, and we have been able to double and triple our attendance. Our reach is incredible. Our reach is patient population, our reach are doctors and healthcare providers, and our reach is global. So if you want to be a part of this conversation and have the visibility and also shared aligned messages, please let us know, and we again can give you more information about being a sponsor. And I think that's it.